we want to appreciate you for taking out time to join this program. Please note that this meeting will be recorded, and we will appreciate that you turn off your mics and on your cameras while on this program. There will be opportunity for you to ask questions at the end of both presentations. We'll be having two presentations today, so there'll be opportunities for you to ask your questions. So please hold on to that point, or you can also put your questions on the chat at any point during the discussions. And please note that at the end of this program, we'll be sharing a link to a Microsoft form where we need to get some details from you. So that we can get details. We need to share CME points to you also at the end of this program. So we'll appreciate that you fill the details on that form appropriately. I'll be inviting our medical head, Specialty Medicine and Programs, Dr. Yewande Obioma, to give us the welcome address for today's program.
Hey, thank you so much, Osaji, for having me. Thank you for the invite. And so maybe I would say thank you to all the distinguished speakers that have graciously accepted to speak on our behalf at Novartis today. Dyslipidemia is an ongoing topic, and I don't think that we can ever talk about it enough, at least until we create the kind of level of awareness to galvanize actions across all strata of healthcare practice, such that everyone who is at risk knows that they are at risk and they are managed appropriately. So thank you so much to all the speakers for accepting to speak, and thank you to everyone who is attending and participating. It shows that you have patients at the center of what you do and your clinical practice, and at Novartis, the patients at the center of what we want to do as well. So wishing you a very engaging meeting, and then we'll be happy to learn feedback from you. And also, if there's an area where you are interested in and we didn't cover in this part of the Congress, so you will have an opportunity to give us some feedback at the end of the meeting as well. So thank you, wishing you all a very fruitful deliberation and meeting as we go along. Thanks a lot again for coming and attending, and wishing you all the best in this particular meeting. So maybe just to reiterate Saji's comments, to please ensure that your cameras are turned off, and then your microphones also are muted. Back to you, Saji. Thank you.
Thank you. Thank you very much, Yewande. So we're going right away to our first presentation for today, but please permit me to introduce our first presenter. Is Dr. Denny. He's an associate professor of medicine at the College of Medicine, University of Lagos, and also a consultant endocrinologist at the Lagos University Teaching Hospital here in Lagos, Nigeria. He's a fellow of the National Postgraduate Medical College of Nigeria and also a fellow of the American College of Endocrinology. Dr. Denny has a lot of publications published in both local and international journals. Dr. Denny is a passionate teacher, and he spends most of his time tutoring medical students and residents. Please help me welcome Dr. Denny, as gives us our first presentation on navigating the management of dyslipidemias as general practitioners. Dr. Denny, over to you.
Thank you very much, Dr. Sage. Can you hear me?
Yes, please.
Okay, so can I share my slide, please?
Yes, you can.
Okay. Can you hear me?
Yes, please.
Okay, all right. All right. Good evening, colleagues, ladies and gentlemen. I must thank you for being part of this program where we are going to share knowledge. And in the next 20 minutes or thereabout, I'll be taking us through navigating dyslipidemia management as a GP. We cannot talk too much about lipid because it is one area of practice that seems neglected in quotes. And the more we talk about it, the better for our patients. This disclaimer is to put it out there that most of the things I'm going to say are mine, and we cannot hold the Novartis responsible for any of those things. And I'm going to follow this outline. I'm going to give a brief overview of this lipidemia, and I'm going to talk about familial hypercholesterolemia. And I will go into gaps that exist in local practice. I'll talk briefly about bridging these gaps, and I'll briefly highlight the effect of inclisiran, its efficacy as add-on to treatment of dyslipidemia. They now summarize. As practitioners, we all know that lipids are not soluble in water, and as such, they are transported in the blood as a complex that is a macromolecule. Now, these lipids, as we know, they are triglyceride, the cholesterol, and the cholesterol esters, and they are stabilized in circulation by a phospholipid. Now, this complex is further covered by a protein that is called apoprotein. And this is what stabilizes the phospholipid that covers this lipid. And this apoprotein actually allows this molecule to be recognized by the receptor on the surface of the liver and in the peripheral tissue. So this complex is now called a lipoprotein. Example is chylomicron, and the structure is spherical, and there are a lot of lipids and protein in each molecule. We always look at lipid as something that is very big, but they are smaller than the red cells, and we can only see them on electron microscopy. But when they are quite large in concentration in the bloodstream, we can actually see them with naked eye. They become milky when we take blood sample, and we can actually tell that the lipid in this sample is quite huge. There are 5 types of lipoprotein in the blood, and these 5 types are the chylomicron, the very low density lipoprotein, the intermediate density lipoprotein, and the low density lipoprotein, which is the most culprit, the major culprit when we talk about cardiovascular disease. Then we have the high density lipoprotein, which is protective to every one of us. Now, the body keeps the lipid at a normal level, so to say. And that is why we have enzymes that are involved in the metabolism of this lipoprotein. We have the lipoprotein lipase that plays a major role in the breakdown of this lipoprotein. And the beauty of this is that this lipoprotein lipase has something to do with insulin. The insulin actually stimulates the synthesis and secretion of the lipoprotein lipase. So you imagine what happens in those who have diabetes, because lipoprotein lipase is not going to be produced as much as it should, and as such, it explains why we have lipid disabnormality in the patient with diabetes, where there is also the lecithin cholesterol acyltransferase and the cholesterol ester transferase. All these plays a role in the lipoprotein metabolism. When we talk about hyperlipidemia, we are talking about a lipid concentration that is high in circulation, and it results from a genetic problem that manifests with interaction with the environment and the individual diet. And when we classify hyperlipidemia, we have 2 classes. The primary, mostly genetic, and the secondary are due to other causes. And what are the other secondary causes of hyperlipidemia? Hypothyroidism. We have patients with hypothyroidism and they have very high lipid level. People with poor diabetes control, obesity, renal impairment, some drugs that we use in our patients could also predispose them to having very high lipid level. Examples are oral contraceptives, the thyroid diuretics, which we use very well in managing people with hypertension, can actually predispose this individual to developing hyperlipidemia. Cutting down on the LDL, which we refer to as hypercholesterolemia, there are two types. We have the heterozygous familial hypercholesterolemia and the homozygous. Now, the heterozygous is autosomal dominant and it's monogenic. Monogenic means it's just an alteration of one gene, and it is very rare. It is not very common. When we say it's rare, the question I probably want to ask us is, do we really look out for it? Because it is there, even though it is rare, but they are still there in the populace. It occurs in about 1 in 500, and most individuals remain undetected, so they don't have any symptoms. So when they come to us, unless we screen for this, they don't have symptoms, but we get to know when a catastrophic effect occurs. And this is due to underproduction or malproduction of cholesterol uptake receptor in the liver. Most of the LDL are transported back to the liver to be broken down, and it lands on the surface of the liver, lands on the receptor, and the receptor takes it into the liver, and it is broken down in the liver, and these receptors are circulated back onto the surface of the liver. I mentioned earlier that they don't have any feature, and the diagnosis is made when we have very high level of cholesterol or when we have some skin changes in this individual. I will show us some pictures very shortly about xanthomas that we can see in this individual, and the family history is one of those things that point us towards this disease in some individuals. Some people have a family history of cardiovascular death in early age. And because we are in Africa, most things are spiritual, and nobody never gets screened. And this continues to run in family. And this is when we need, as practitioners, to look out and screen these individuals. These are things we can see in people with familial hypercholesterolemia, that is heterozygous. This is Achilles tendon xanthoma. You can see the Achilles tendon thickened there. Now, for the homozygous, it is even very, very rare compared to the heterozygous one. In this condition, there is no HDL receptor at all in the liver. So you imagine what happened to the LDL cholesterol. It cannot be broken down. And so the concentration in the blood is very high. And most of these individuals, they don't live beyond childhood or adolescence. In some cases, if they are picked earlier, statin do work for them, but the most treatment is plasmapheresis, and with minimal success when they do this plasmapheresis to remove the excess LDL. The focus of treatment is liver transplantation, and this is one thing that is not readily available or combined. And this is what we have in homozygous hypercholesterolemia. You can see the plantar xanthoma in this individual. Looking at the global epidemiology, you can see on this slide, we have the global, and we have the men and the women. We have the sub-Saharan Africa, the Western Europe, and the high-income North America. Now, if you look at this slide very well, to the left, when we look at the total cholesterol, you can see between 1980 and 2018, which is what the data is showing, there is a reduction when you look globally and in Western Europe and high-income North America. However, it is not so in sub-Saharan Africa. If anything, there is an increase from 1980 to 2018 in the cholesterol level in those who have dyslipidemia. In a systematic review, looking at this data from 1980 to 2017, in 177 studies, it shows that in sub-Saharan Africa, we have about 25% of people with total cholesterol that is elevated. About 29% has elevated LDL cholesterol, and the triglyceride is found in about 17%. Courage et al. Also looked at did the meta-analysis, and they looked at cardiovascular disease and what is driving it. And overall, they find out that in those who have cardiovascular disease, 38% of them have dyslipidemia. Those who have ischemic heart disease, about 50% of them have dyslipidemia. And those who have stroke also have 6% have hyperlipidemia. So we can see that dyslipidemia actually drives the cardiovascular disease in this individual, and the prevalence is not different from what we have in Western Europe and among us here. This is a worldwide prevalence, and you can see that this beautiful slide showing the world map, and you can see to the left the various frequency of familial hypercholesterolemia. Now, that circled area, that is where we belong in Africa. And 90% of places in the world, we don't know the frequency or the prevalence of familial hypercholesterolemia. And so, is it that it is not there, or we are not looking for it? And that is one of the messages we should take away from this session, that we actually need to look for these things so that we can help our people suffering from this condition. Familial hypercholesterolemia in Africa, the PubMed search using all these terminologies retrieve about 20,000 articles, and only 446 of them are from Africa. That's about 2.2% contribution from Africa to the global population. And when we even break this down further, most of these publications are from South Africa, 34 from Nigeria and 8 from Ghana. So we can see that in all other African regions, these people with familial hypercholesterolemia are probably missed, and they die because of the consequences of not getting treated. Coming down to cardiovascular disease, it's an heterogeneous condition that consists of atherosclerotic cardiovascular disease and non-atherosclerotic cardiovascular disease. And under the ASCVD, if you permit me to use that term, coronary artery disease is there, the carotid artery is there, and the peripheral artery disease. The non-atherosclerotic cardiovascular disease include the congenital heart disease, the rheumatic heart disease, and the cardiomyopathy. There are modifiable risk factors and the non-modifiable risk factor. Age cannot be modified. Our ethnicity cannot be modified. Neither can we modify gender. We won't go into the discussion of, I think I am trapped in the wrong body. We can't change the gender. The genetic composition of individual is there. Then we have the familial, which is a genetic thing that cannot also be altered. So how does LDL-C contribute to atherosclerotic cardiovascular disease? The higher the LDL-C cholesterol, the more we have this atherosclerotic cardiovascular disease. And it starts with exposure to very high level of LDL-C, and a plaque is formed, and this plaque ruptured. And when it ruptured, it's from a thrombotic effect. This thrombus can go to block a coronary artery or the carotid artery, and ischemic stroke can occur, or a myocardial infarction will occur. In familial hypercholesterolemia, the problem there is either the LDL receptor is absent, or there's a problem with ApoB, or the PCSK9 is also absent. PCSK is that enzyme that is produced in the liver that block the production of the LDL receptor. And so that's why we have the PCSK9 inhibitor in treating this patient. If you look at this slide, the summary is that the longer we expose an individual to high level of concentration, there's a threshold at which an event will occur. Now, if you look at that lower dotted line, that is the cumulative threshold. Now, if an individual is running LDL cholesterol of 80 milligrams per DL, by 60 years, it will reach that threshold. And we expect that by 100 years, that person will probably have a myocardial infarction. Let's now imagine that that concentration has gone to 125 and the individual is exposed to that dose. By the age of 40, that threshold will have been reached, and that person will probably have an event by 62 years or thereabouts. At a higher level of cholesterol, 200 milligrams per DL, the threshold that will be at about 20 years, and by the time the person is 38 or thereabout, that person will definitely have MI. So it shows that we need to actually target the LDL cholesterol so that we prevent events in our patients. So what is the gap that we have in our local practices? I'll talk about what we have in Nigeria, and I'll share. I'll listen to what the experience is in Ghana. In terms of risk assessment and screening in the primary healthcare, it's not there. Secondary healthcare centers, we have the risk assessment, but it's not routinely done, and screening is also for selected people. In the tertiary healthcare center, it's only the people who are at risk that are screened, and they are the ones that are actually treated. And how do we make a diagnosis? We need to do all this. As practitioners, we know what to do. But the question is, are we really targeting the people that we need to treat? There is a clinical benefit of lowering LDL cholesterol, and the benefit is simply that we reduced or modified the cause of ASCVD. Do we have guidelines? Nigeria, no, we don't. And in most places, we rely on the European Society guideline or the ACE guideline. So what are the unmet needs? There is a web-based study by Akitunde et al. In Nigeria, and he looked at the knowledge and management of dyslipidemia among physicians. Surprisingly, the experts are not even managing it very well, and it highlights that there is substantial gap in knowledge and management of dyslipidemia, even among experts in Nigeria. Da Vinci also discovered that most of the patients are not getting to target, even though they are on treatment. And there are reasons adduced for this. Practitioners are not familiar with the guideline. The cost of treatment is very high. Reluctance of patients to be treated with very high intensity lipid lowering therapy, and concern about side effects. And these are things that will not get people to attain the LDLC control that we have. Do we have the medication available? Yes, of course there are. The traditional medicines are there, the statins, esentimide, the bile acid. We have the inclisiran, bempedoic acid, and so on and so forth. And these are available, but can the patient access this care? That is another gap in treatment. Even those who are on statin are receiving the dose very well. 80% of them don't get to maintain that target. Even after they've met the target, they lost it and they remain suboptimally treated. Most of the time when we see our patient, we rarely do the risk assessment. And this is one thing we must take away from this meeting. We must try to assess the risk in our patient with all these tools that are available to us, assess the risk, and that will guide us in either we put them on low intensity statin, moderate intensity, or high intensity. And we must follow them up so that when they are not getting to target, we should hold on until we get them to target. We should not wait until they have an event which can be very catastrophic. Now, this is the European guideline, and you can see that it starts with assessment, and if there is very high level of LDL cholesterol, treatment is commenced with a high dose statin. If the patient is at target, we follow the patient up. If the patient is not at target, esentimide is added, and we go down the line until we had PCSK inhibitor, and inclisiran will come in at that stage because it's meant to be an add-on to the statin when the patient is on therapy. So how do we plan to bridge this gap? We must look inward. We must have our homegrown algorithm. And that's why the Novartis gathered us together some time ago at the Dyslipidemia Advisory Board meeting. And we came up with this. I apologize, it could be very tiny to read, but it's similar to what I projected, but in a simpler form that we can domicile in our practice and be able to offer better treatment to our patients. So how does inclisiran work? Is the first and the only therapy that utilizes small interference RNA. We all know that the receptor for LDLC is on the liver, and when the LDLC lands on this receptor, it is internalized into the liver, and the receptors are recycled outside. I told you earlier that the PCSK9 is also synthesized in the liver, and it interferes with these receptors, and as such, most of the receptors are not recycled back onto the surface. Now, what inclisiran does is to even block the production of PCSK9. It does not inhibit it like we have the PCSK9 inhibitors. No, inclisiran makes sure that PCSK9 is not produced, and as such, we have more of the receptors recycled to the surface of the liver, and the LDLC can be broken down. Does it work? Yes, it does. And I'm going to answer that question looking at three studies, the Orion 9, Orion 10, and 11. In Orion 9, we have those who have heterozygous familial hypercholesterolemia. In Orion 10, we have those who already have a cardiovascular disease. And in 11 is those who have the risk equivalent of cardiovascular disease. And this is the protocol. I'm not going to take us through the details. But the outcome is that we can see the reduction, almost 40% reduction in Orion 9 for those who have familial hypercholesterolemia, more than 50% reduction from baseline of LDL-C cholesterol, and more than 45% reduction in Orion 11 for those who have cardiovascular risk equivalent. Now, this shows the percentage of individuals reaching the goal who have more than 50% reduction in LDSC. And you can see in Orion 10 and Orion 11 that we have almost 73% and 58% individual having more than 50% reduction in LDLC from the baseline. Now, when you look at inclisiran and the percentage of individual getting to the threshold at the end of that trial, you can see that 65%, 83%, and 81% respectively in that order were able to reach those targets. Now, this, if you look at it in terms of gender, age, their baseline starting, and other metabolic disease they have, this does not influence it. Everybody in this category were able to get to the set target in the study. So, summarizing the efficacy of inclisiran, 2 doses is enough to get the patient to target, and it is effective and it is sustained. And the decrease was observed across the pre-specified subpopulation, including patients with metabolic disease and or impaired renal function. Is it safe? Yes. And you can look at this safety looking at adverse effects and serious adverse effects. Compared with placebo, you can see that it is not different from what we have in inclisiran and the placebo in Orion 9, in Orion 10, and Orion 11. Most of the side effects are not debilitating that will make an individual not to have inclisiran. If you ask me, do I have any experience with it? Yes, I do. And the patient I put on it has reported no side effect, not even at the injection site. Now, we are always worried about the kidney, and there is no dose adjustment of inclisiran that is necessary, even in patients who have renal impairment. So, there are other studies going on that will evaluate the effect beyond 1 year. We're talking about 4 years, and Orion 3, Orion 8, and Orion 4 will be able to answer this in the nearest future. To summarize, I have taken us through atherosclerotic cardiovascular disease as a leading cause of disease and morbidity and mortality. Current evidence suggests that elevated LDL-C is the most readily modifiable risk factor of atherosclerotic cardiovascular disease, and lowering this LDL-C directly leads to significantly improved cardiovascular outcome, regardless of the lipid-lowering therapy used. And many patients treated with statin-based lipid-lowering therapy are unable to consistently achieve or maintain their LDL-C target, and as such, they will need an add-on like inclisiran, to get them to target and prevent morbidity and mortality in this individual. Thank you very much for your time.
Thank you very much, Dr. Denny, for that beautiful presentation on the management of dyslipidemia as general practitioners. I'll be moving on to the next presenter, and I will hand over to my colleague Evelyn to introduce our next presenter. Over to you, Evelyn.
Thank you very much, Sajay. Thank you very much, Sajay. Kindly share the speaker's profile for us to move on.
Can you see my screen?
Not yet.
Is it up now?
Yes, it's up. Yeah. Slide
Okay.
mode. Presentation mode, please.
Yes, please. It's coming up.
And thank you, Dr. Udeni, for that excellent presentation. Our next speaker is Dr. Stildazi. Dr. Stildazi is a senior family physician at the Finney Hospital in Ghana, Accra, Ghana. He is a training and a research coordinator at the Kolebu Teaching Hospital Polyclinic Department. He is also the training coordinator for the Family Physicians Medicine Residency Program at the Kolebu Teaching Hospital. He is a trainer of trainers at the Ghana Cardiovascular Disease Management Heart Initiative. He is also a fellow of the Ghana College of Physicians and a member of the West African College of Physicians. So that will be speaking on the topic lipid management, key to ASCVD prevention. So we'll now hand over to Dr. Stildazi to present on this topic.
Thank you very much, Evelyn, for your kind introduction. So I'll go on to share my slides. Right, please, can my screen be seen?
Yes, please, we can see your screen.
Yes, we can see
Right,
your
thank you
slide.
so much. And I really appreciate Prof for the very thorough presentation, which indeed has made mine very much easier. So thank you, and thank you so much for the organizers for the privilege of having me as part of the presenters. Just a little point of correction about the introduction. I've relinquished my Kolebu association. So currently, my position at Kolebu Teaching Hospital is no longer valid. I'm fully at Finney Hospital. So that's just a little bit of correction. So my task this evening, let me say a big good evening to all of our listeners. And I hope this session will be very beneficial to all of us, especially to help us upscale or improve our management of this very important condition, which, as Prof has beautifully presented, is very much contributory to the cardiovascular disease burden. So the title of my presentation is Lipid Management, Key to Atherosclerotic Cardiovascular Disease Prevention. And it's obvious from Prof's presentation that indeed
We lost Dr. Stildazi. He'll be joining us again shortly. Can you hold on?
Yeah, I'm very much very sorry for I got lost on the way. Am I back, please?
Yes, you're back, but it's on slide mode. If you can kindly put it on presentation mode.
All right. Well, is that okay?
Yes, you're up now. Thank you.
Right. So this presentation will focus on the management of dyslipidemia with a view to prevent atherosclerotic cardiovascular disease. And as I said earlier, Prof has done much of the work and has made mine so much easier. So this is a disclaimer from Novartis. What are the expected learning outcomes from this presentation? At the end of this presentation, listeners are expected to learn how to categorize cardiovascular disease risk of patients. So as Prof presented, when we have patients with cardiovascular disease risk, we hardly categorize them. So we'll actually delve into the practice of categorizing the patient appropriately. And then based on the categories, we will learn how to set lipid lowering goals and then use appropriate lipid lowering therapies to achieve the targets set with the overall aim to minimize cardiovascular events and deaths. So this is the outline for the presentation. Prof has already talked about the need to pursue lipid lowering as part of the strategies for reducing atherosclerotic cardiovascular disease burden. I'll also look at risk stratification and then present what is recommended in the Ghana guidelines on lipid lowering and how to achieve lipid targets in practice. So as Prof has presented, cardiovascular disease are indeed the major causes of deaths globally, and particularly premature deaths, defined as deaths before 70. Unfortunately, about 80% of premature deaths occur in our part of the world. And atherosclerotic cardiovascular diseases are very important components of cardiovascular diseases. And Prof has already gone through this, so I will skip this slide. And again, we know that elevated LDL cholesterol is a key risk factor for cardiovascular diseases. Globally, elevated LDL cholesterol is noted to be the third most important risk factor for cardiovascular diseases after hypertension and dietary risk factors. That is based on analysis by the Global Diseases Burden. And it contributes to as many as 3.81 million deaths per annum. There was a study done to assess the risk factors for strokes in Ghana and Nigeria, known as the Siren study, which I'm sure some of us have heard about. And this study looked at 2,118 cases of stroke. And dyslipidemia was found to be the second leading cause of strokes in Ghana and Nigeria after hypertension, accounting for 35% of cases of stroke. And the study rightly recommended targeting the management of dyslipidemia as part of the multi-pronged approach to prevent stroke. So we cannot overemphasize the importance of lipid lowering in preventing atherosclerotic cardiovascular disease. The main goal of the management of atherosclerotic cardiovascular disease is to prevent cardiovascular events such as strokes or ischemic heart disease by reducing cardiovascular risk. So the patient that comes to us has cardiovascular risk, and our job is to manage these risks to prevent them from having cardiovascular events like MI and strokes. The core components of prevention of cardiovascular disease are lifestyle modifications. So we know about some of these: exercise, cessation of cigarette smoking, etc. Then also we have CV, cardiovascular risk factor management. This is managing the risk factors that the patients have, like hypertension, dyslipidemia, etc. Others are antithrombotic therapy. Then disease-specific treatment, like diabetes and chronic kidney disease management. And also, very importantly, to address psychological factors. But this afternoon, our business is to look at the management of CVD risk factors and specifically dyslipidemias. So Prof has talked about the fact that lipid lowering is key to prevent atherosclerotic cardiovascular disease. And the risk of is being projected. I read an article where an expert in lipid management is projecting that with the discovery of effective lipid lowering therapy, such as statins, ezetimibe, and PCSK9 inhibitors, if these are properly used, there is a chance that in the near future, dyslipidemia will be driven to the bottom among the risk factors for cardiovascular diseases, and that will take all of us doing the right thing. It will be happy to see that the burden of dyslipidemias is reduced with the overall effect of minimizing cardiovascular disease events and deaths. There is ample evidence to suggest that lipid lowering reduces atherosclerotic cardiovascular disease. And evidence shows that the lower the levels of LDL attained, the greater the reductions of ASCVD events and death. Lowering LDL cholesterol levels is very safe. There was a concern that because LDL itself is useful in the body, for example, it's an important component of cell membrane and also used in the manufacture of certain hormones. Reducing it too low might have adverse implications on the body, but studies have shown that it can be reduced severely. There was a study dubbed the Improve It study. I'm sorry, I lost connection briefly. So the Improve It study revealed that the body can tolerate very low levels of LDL cholesterol. For example, in that study, the attained LDL of participants was as low as 0.78, and it was found to be very safe. So lipid lowering is very important. How do we manage CV risk in clinical practice? The following are the steps that we are to pursue. One is to assess the cardiovascular risk, and based on the cardiovascular risk of the patient, we categorize the risk of the patient, and I'll go into details on that. And based on the risk of the patient, we determine the goals for the LDL. We discuss the goals with the patients and their families in a shared decision manner and offer interventions and encourage patients to be adherent. And when we put patients on lipid lowering therapy, it doesn't end it because, as Prof said, quite often the targets are not achieved. We should aim to reassess patients for the attainment of the target set. And this is quite one of the areas that we are lacking. We don't quite assess patients. Once we put them on lipid-lowering therapies, we leave them and hope that the targets will be achieved. But we should pursue reevaluation of patients to ensure that targets are achieved. And as we assess the patients for the attainment of targets, if targets are not achieved, we should optimize or intensify therapies to achieve the targets. So achieving targets in lipid lowering is very key. Merely giving patients lipid lowering therapies does not optimize outcomes of lipid lowering therapies or treatment. So how do we go about categorizing patients' cardiovascular risks? Now, first of all, the risk categorization considers the following. First of all, does the patient have an established atherosclerotic cardiovascular disease like myocardial infarction or ischemic stroke? And this is a question we should always ask. Secondly, does the patient have clinical conditions which increase the risk of cardiovascular disease like diabetes mellitus, chronic kidney disease? Does the patient have target organ damage like left ventricular hypertrophy or increased urine albumin creatinine ratio? Thirdly, what cardiovascular risk factors does the patient have? And this we consider modifiable and non-modifiable risk factors as Prof presented. And what is the patient's cardiovascular risk prediction score? Prof projected the risk assessment chart, which I will also project. Now, the risk assessment chart is only a part of the risk assessment of patients. It is not the only, it is just a component of the overall risk assessment of patients. So based on with this, you should also consider the patient's age, frailty, and then affordability. What are some of the lapses in clinical management of cardiovascular disease or lipid lowering? So ineffective clinical care contributes to cardiovascular diseases, and lapses in clinical management include not assessing the cardiovascular risk of patients and not categorizing the patients appropriately. If you don't do that, how do you know where the patient is and what to give the patient, what target to achieve? Not setting clear goals for lipid lowering. So if you are giving your patients lipid lowering therapies, where do you want to get to with your LDL cholesterol? No clear or documented targets for CVD risk reduction. And then we also don't monitor our patients for the attainment of these risk reductions. How many of us really monitor our patients? Quite often, we give them the drugs and leave them. So what are the cardiovascular risk categories? We should consider these groups of patients: patients with established atherosclerotic cardiovascular disease, patients with specific CV risk conditions, mainly diabetes, chronic kidney disease, severe or familial hypercholesterolemia. What do we mean by this? If a patient is presenting with lipid profile and total cholesterol is 8 or more, or LDL cholesterol is 5 or more, these patients have severe dyslipidemias, and they have high cardiovascular disease risks. Target organ damage, are they present? Patients who don't have any of these are described as apparently healthy individuals. And these are patients who may have some risk factors, but do not have established cardiovascular disease or CV risk conditions like diabetes or chronic kidney disease, or do not fall in the category of 0.2 above. So based on these, there are four cardiovascular risk categories. They are very high risk, moderate risk, and low risk. We have to note that until recently, there were only 3 categories, the high risk, moderate risk, and low risk. But now we have the addition of very high risk. What are those at very high risk? Those are those who already have documented atherosclerotic cardiovascular diseases. They may also have atherosclerotic cardiovascular disease on imaging. For example, a patient may have significant carotid artery stenosis from atherosclerotic plaques. Patients with diabetes who have significant target organ damage are very high-risk patients. And patients with severe CKD defined as eGFR of less than 30. And those with very high cardiovascular risk scores. Then we have high risk. These are patients with for example, somebody with total cholesterol of 8 or LDL cholesterol of 5, very high blood pressure, grade 3 hypertension, people with diabetes, but without very significant target organ damage will fall into this category. Patients with hypertension with LVH, that's left ventricular hypertrophy, CKD, that is moderate, eGFR between 30 and 59, and then moderate cardiovascular risk score. Then we have those with moderate risk and low risk. So this is how we categorize our patients. And after we categorize our patients, what do we do with these categories? We discuss with the patients and then decide on personalized treatments.
Apologies, we've lost Dr. Stildazi again. He will join shortly.
Yeah, please, can I be heard now?
Yes, we can hear you and we can see your screen as well.
Right, sorry for what happened. So I was talking about how to use the cardiovascular risk prediction tools. I mentioned that there are several of them. The one that is specific to us is the WHO AfroD one, which Prof projected. And what do these tools do? They predict the risk that an individual will have an atherosclerotic cardiovascular disease in the next 10 years. And this is how it looks like. So on this, you see 2 zones. One zone is for people without diabetes. The other is for people with diabetes. So the panel on the left is for those without diabetes, and the one on the right is for those without diabetes. So in using this, first question you ask is, does my patient have diabetes? If the patient has diabetes, Then you use a chart on the right. The second question is probably the easiest, hopefully, and that is is it a man or woman? So if it is a man, use that on the left side, woman on the right. Then the next is, does the person smoke cigarettes? And then what is the person's age? So the age is in decades. And the next questions are, what is the person's total cholesterol and blood pressure? So I hope you can see the cursor. Let's say we have a patient who has diabetes, who is 50 years old, a female patient who doesn't smoke cigarettes and has total cholesterol of 6 and systolic blood pressure of 160. So the patient has diabetes, so we come to the diabetes panel. A woman, so obviously here, she's a non-smoker, so she comes to this area, this region. She's in her 50s, so it brings us here. Then this patient's total cholesterol is 6, so that brings us here. And then total blood pressure is 160, which is on this side. So that means that this patient has, it falls into this box. And there is a figure in each box. The figure I see, if I can see correctly, is 12. So what it means is that this patient's risk of having an atherosclerotic cardiovascular disease in the next 10 years is 12%. What do we do with the 12%? We come up here, and then you see that there are color zones with percentage ranges attributed to them. So we have those with less than 5% risk level, 5 to 10, 10 to 20, 20 to 30, and then more than 30. So our patient falls here, and that is high risk. Patients more than 30 are obviously very high risk. And those within more than 20 are also very high risk. But there are times that they may qualify as high risk within this zone. Those in this zone 10 to 20 are very high risk. 5 to 10 are moderate risk, and then less than 5 are low risk. So when you do this assessment, it gives you an idea, and you combine it with the overall risk of the patient. It's not the only risk, only the cardiovascular risk of patients. Right. So let me quickly go through this case. I think it's similar to the one I presented, a 56-year-old woman who has diabetes and hypertension presenting for review. She does not smoke. She does not have a prior history of atherosclerotic cardiovascular disease. Her blood pressure is 168/94, total cholesterol is 6.4, so very much similar to what I presented. So the question is, what is a atherosclerotic cardiovascular risk category? This is not asking what is the atherosclerotic cardiovascular risk score. It's asking about cardiovascular risk category, and it's different from the score. So here, what we do is, first of all, ask yourself, does the patient have an atherosclerotic cardiovascular disease? If she does, straight away, she is in very high risk. You don't even need to assess the cardiovascular risk score. Next, ask yourself, does the patient has a specific disease that increases cardiovascular risk, like diabetes? Yes, this patient has diabetes, which makes her at least a high-risk patient. Then the next thing you do is to estimate her atherosclerotic cardiovascular risk using the chart, which we did. And that gave us a high risk. So this patient, putting all together, is a high-risk patient. Now, after we've categorized the patient, what do we do? This risk categories is what helps us to individualize the patient's lipid lowering. And how do these categories help us? They help us to set targets. For every CV risk category, there is a recommended target. So starting from very high risk, the recommended target currently is that the LDL cholesterol should come to less than 1.4 millimole per liter. For high-risk patients, LDL cholesterol should come to less than 1.8, or at least we should attain more than 50% reduction from the baseline value. For moderate risk, LDL cholesterol should be reduced to less than 2.6, and for those at low risk, less than 3.0. So that's how useful the risk categorization is. So now let's go on to what is recommended in the Ghana guidelines on lipid lowering. The Ghana guidelines was published in 2019, and we did a focused review last year, but it's yet to be published. I was privileged to review this particular chapter. So what I'm presenting is actually a combination of what is in the 2019 guidelines and what we recommended in the focused updates. So based on this, for patients are categorized based on age and risk factors. So first of all, for patients who are young, 20 to 21 years old, if they have a history of suggestive of familial hyperlipidemia or a history of premature atherosclerotic cardiovascular disease, then you consider their LDL level. If their LDL level is more than 4.1, then you consider starting therapy. But for such young patients, if LDL level is low, sometimes the laboratory figures may indicate that their LDL level is high, 3.4 and above. It doesn't necessarily mean you should put them on lipid lowering therapy. You should consider whether there's a family history of premature atherosclerotic cardiovascular death. And in that context, is LDL level above 4.1, then you can start starting therapy. But for those with that within the ages of 40 to 75, the first question to ask is, do they have diabetes? If they don't have diabetes, what is their LDL level? If their LDL level is between 1.8 to 4.9, that is less than 5, then what you do is to risk categorize them. And normally they will fall into high risk, moderate risk, or low risk. And based on these risk levels, you start appropriate lipid lowering therapy, aiming to reduce the LDL level to the targets that I mentioned earlier. What about adults whose LDL from the beginning are 5 and above? Now, one of the points we should pick from here, from this presentation, is that once a patient's LDL is 5 and above, or total cholesterol is high, 8 and above, that patient has severe hyperlipidemia. And we need to start not only statin therapy, but high intensity statin therapy. For patients with diabetes, chronic kidney disease, as I said earlier, these are high-risk patients, and their LDL levels must be reduced to less than 1.8, or by at least 50% of baseline. For patients with established atherosclerotic cardiovascular disease or very high risk cardiovascular, very high cardiovascular disease risk, the recommended target is less than 1.4. Or the worst we can do, or the least we can do, is that we should reduce the LDL by 50% of baseline. So when we put the patients on these therapies, what do? You monitor them. You measure the lipid levels within 4 to 6 weeks and find out whether you have attained your targets. If you have not attained your targets, then there is room for intensifying your therapy. What does intensification of therapy mean? Either you increase the dose of the initial therapy, which is the recommended is statin, or you do an add-on. So this is the recommended doses for statin therapy. For those with, it's categorized based on the risk level. For those at low risk, what is recommended is simvastatin, 10 to 20 milligrams at night. Simvastatin is preferably taken at night. Those at moderate risk, we can do atorvastatin 10 to 20, rosuvastatin 5 to 10, or we can also use simvastatin 20 to 40. But those at very high risk or high risk, our only options are atorvastatin and rosuvastatin. So atorvastatin 40 to 80, and rosuvastatin 20 to 40. Now, as Prof presented, there are so many patients who do not achieve lipid-lowering targets with statins. And this may be due to the fact that, by nature of that therapy, many patients are unable to attain the targets even when they are compliant. But non-compliance is also a big problem, and some patients have side effects such as myopathies. So with this, what is recommended is to add on, and there are options to add on which Prof presented. So I need not go into the details. They include ezetimibe, which is given as 10 milligrams daily. And then we also have inclisiran, which, as Prof said, is a highly effective medication. And fortunately, is given subcutaneously at 6 monthly intervals. Can you imagine a drug that is effective at lowering your lipid levels and is given every 6 months? A patient like me who doesn't like taking medication, I think will very much benefit from that. So I think because of time, our Prof has taken us into details about the specific PCSK9 inhibitor that we have on the market, which is inclisiran. He's talked about its mechanism of action, so I won't go into details. So let me end by just presenting this case. A 56-year-old woman who is known to have diabetes mellitus and hypertension, similar to the one I presented. She had an ischemic, this patient had an ischemic stroke 3 years ago. And at this time of presentation, her total cholesterol was 7.7 and LDL cholesterol of 5.2. At review, the total cholesterol had reduced to 5.3 and LDL to 3.0 after 1 year of optimal treatment with atorvastatin. She does not smoke, and she's also on other medication. Her eGFR is 6.1. So how would you go about her lipid lowering? So first of all, this patient risk category, because she has an atherosclerotic cardiovascular disease, straight away, she is a very high risk patient. And if you remember the targets that I mentioned, what would be her target? Certainly, we should attain an LDL of less than 1.4. But after 1 year of treatment, we are happy that her LDL has reduced from 5.2 to 3.0. But is she on target? The answer is no. We are expecting to get to 1.0. This is far off. So what would we do? We have to add on. And the options are to add on ezetimibe or a PCSK9 inhibitor. Currently, there's recommendation that patients who are very high risk and who have high cholesterol to begin with, we can start right from the beginning with combination therapy rather than start with statin and then observe. We should bear in mind that from Prof's presentation, the lower the target we achieve, the lower the risk of subsequent atherosclerotic cardiovascular event or even a primary atherosclerotic cardiovascular event. So with this, I'm sure we've learned how to go about lipid-lowering therapy, how to risk categorize our patients, how to set targets, how to initiate and monitor therapy, and what to do when we are not achieving our targets. So going from this presentation, we have to pay keen attention to dyslipidemias among cardiovascular risks. We should be up to date on how to manage this, know how to risk categorize our patients, how to achieve targets, and when we are not achieving targets, how to optimize. So thank you very much, and sorry for the hiccups in my internet connectivity. Thank you.
Thank you very much, Dr. Stildazi, for that excellent presentation. My colleague Saji will handle the question and answer session. So if Saji, please go on.
Yes, please. Thank you, Lynn. Yeah, so I want to once again appreciate our speakers for the wonderful presentations. Thank you, Dr. Denny, and thank you, Dr. Stildazi. So please, if you have any questions, you can go right ahead and maybe signify by raising your hands while we will take your questions. You can also drop your questions on the chat group, the chat here on Teams. I think I already see two questions. One of the questions there is, what's the role of elevated triglycerides in CV risk? I think I will hand that over to Dr. Stildazi to take care of. What's the role of elevated triglycerides in CV risk?
Yeah, so elevated triglycerides is also an important risk factor for CVD. When triglyceride is elevated, that is when it is 1.7 and above. There are a few cases where individuals will have isolated triglycerides elevation, and that contributes to overall cardiovascular risk. And there are other conditions that it predisposes to, like pancreatitis, etc. So very much elevated triglycerides is also an important CVD risk factor.
Thank you very much, Dr. Steele. The other question here, a participant here said he would like to know if CV risk in pregnant women, would like to know about CV risk in pregnant women with regards to dyslipidemia and its management. I think I'll hand that over to you again, Dr. Steele. Is there a different approach to CV risk stratification in pregnant women? Or how do you manage dyslipidemias in pregnant women?
Yeah, so thank you very much. So as Prof presented, Prof made an important statement that a person's lifetime exposure to high cholesterol increases cardiovascular risks. So exposure to high cholesterol levels in a person's entire course of life, including pregnancy, increases cardiovascular risk. So very much cardiovascular risk the management of CVD risk should also be, it continues during pregnancy. Pregnancy is not exempt from CVD risk reduction. I'm not sure about the safety of statins in pregnancy, so maybe Prof can help with that. In my clinical practice, I don't quite remember putting pregnant women on statins. So maybe I'm not sure whether Prof can help us with that.
Okay, thank you very much. Very good presentation, Dr. Sarah. Now, in pregnancy, most medications are not approved, but what is approved in the management of dyslipidemia is the bile acid sequestrant. That's the cholesevelam. That can be used in pregnant women who have dyslipidemia. Uh, it's just because there are no randomized control trial, and it's going to be difficult to get any board to approve such study in a pregnant woman. So the study, there are some people that have used uh, like a sentimib, but it's just a case report. And you know, we don't base scientific decision on case reports. However, there are reviews going on and meta-analysis that may probably show that the use of statin in pregnancy may not be detrimental after all. And the thought here is, what about the pregnant women with heterozygous familial hypercholesterolemia with a very high cholesterol level? They need to be managed, and because we are not sure of the safety of the PCSK9 inhibitors and all that. So, but with the meta-analysis coming up, we may be able to at least have a fact to hold on in treating these women. But looking forward, I think inclisiran also is being looked at in one of the literatures I review. Looking at inclisiran may hypothetically be very interesting option because it actually can be used in this individual that have very high LDL-C cholesterol before pregnancy. Don't forget that it's given twice a year, every 6 months. And we know that the effect is there. So it might actually be, if we, just like Doc said, we are able to look at the risk and stratify the patient very well. This individual can actually benefit from a very good control before they get pregnant. And inclisiran may probably be the way to go for them. They get it before they get pregnant. And in the course of pregnancy, they may not need to use it until after they've delivered. But the study is still on. We hope that when the result is out, we'll be able to have a final decision on this.
Thank you very much, Dr. Denny. Another person wants to know if there are medications that can raise HDL levels in the body. I don't know if Dr. Denny can help us with that.
No, there is no drug position to reach HDL. It's exercise is one thing that has been shown to raise HDL. There are some, for those who read very well, some statins have been postulated to actually raise HDL level. For example, if for those who have followed the trial of rosuvastatin, somewhere along the line, there is some appreciable increase in HDL, but that is not what the medicine is positioned for. So there is no specific medication to raise HDL. Exercise and others have been prescribed, and that is what is there for now in literature.
Okay. Thank you very much, Dr. Denny. So I have two questions on the chart, and I think both are related. And so I think the participants would like to know the role of diet and exercise in dyslipidemia management, because most of the things here are statins. And so when you want to say you want to refer a patient or start with lifestyle modification and diet for a patient, or at what point do you want to refer to say these patients should just stick with lifestyle modification and statins? I think I'll start with you again, Dr. Denny, before I go to Dr. Steele.
So even though we've presented this as if it's all about medication, it's not all about medication. They all go together. We cannot remove lifestyle management. From my experience, very, very few of the patients do well on lifestyle modification alone. I probably want to listen to Dr. Steele's experience in Ghana about lifestyle. Majority of the patients will not do well on lifestyle, but we need to combine lifestyle with the choice of medication that we're picking. Now, when we are combining lifestyle, one thing he mentioned in the presentation that is very, very key is that we must give appropriate dose. Sometimes we underdose. So sometimes we start the statin at the lowest minimal dose and we're not seeing a response. So the lifestyle comes with it, exercise, diet comes to that, except in some patients or individuals who cannot tolerate statin. And we have them, they can't. I have a patient who can't tolerate statin, and in such, you probably need to lay emphasis on the lifestyle plus other molecules that will help such individual.
Okay. Over to you, Dr. Steele.
Yeah, thank you very much. So lifestyle, as I presented, is very much a part of the strategies for preventing cardiovascular diseases in general. And when we are recommending lifestyle, the focus should be minimizing cardiovascular diseases in general and not just lipid lowering, because the benefits of lifestyle is beyond the specific effects on the lipid profile. There's so much to gain from lifestyle, which affects almost all the risk factors or cardiovascular diseases. So lifestyle is very much a component of the management of cardiovascular diseases. But I agree with Prof. In my own practice, our lifestyle is very difficult for patients to achieve. Talking about exercises, very few patients are able to achieve recommended exercise regimes. Even diet, very difficult. And all of us, I mean, many of us, I believe, will attest that it's very difficult. In fact, one of the people my patients don't like seeing are the dietitians, because they're always afraid that they will ask them to drop some of their pet diets. So, I mean, generally, lifestyle, adherence to lifestyle recommendations are quite low. But for patients who are able to adhere to them, there is ample evidence to suggest that they are very efficacious. And they are first line in the management of cardiovascular diseases. What we shouldn't do is to develop a culture of going straight to pharmacological therapies without recommending lifestyle. So even though we have said that adherence to lifestyle is limited, we should still recommend them and encourage patients as much as possible to adhere to them. Thank you.
Thank you very much, Dr. Steele. So another question here is this. I think that will be directed. Yes, please.
Yes, we have participants joined on CES platform, so they can also type in their questions, and then it will be sent to us for it to be read to the presenters. Please go ahead.
Okay. Thank you very much, Evelyn. So another question here is this. I think that will be for Dr. Denny. So is there a difference between dyslipidemia and hyperlipidemia?
Okay, so dyslipidemia, we expect the lipid parameters, the total cholesterol, triglyceride, HDL, LDL, to be within acceptable range in all individuals. The moment we have one out of those going out of the acceptable limit, it becomes a dyslipidemia. Now, either it is low or high, but most of the time we are worried about the elevated level of these lipids. Now, we use them interchangeably. Hyperlipidemia simply means it is high. Dyslipidemia means one is out of place, and whichever one is out of place most of the time is high. So it's what we use interchangeably when we say a patient has a dyslipidemia. One of those lipid parameters obviously is high. That is what we talk about there.
Okay, thank you very much, Dr. Odeni. So the number 2 question is asking about a drug. So what's the role of esverol as an add-on in the management of dyslipidemia? I don't know if you've heard about that before.
Okay, I think resveratrol, it's one of the polyphenol. It's an antioxidant. It's not been positioned to actually manage lipids. The literature I've read about it, I hope I remember very clearly. It's when you talk about a drug doing so many things, that drug is not doing anything after all. So it's said to protect against cardiovascular disease, cancer, liver disease, obesity, diabetes, etc., etc. So it's more like an antioxidant, if I put it that way, that belongs to the class of drugs that we call, group of molecules that we call polyphenol. And it doesn't do more than that, more than it's an antioxidant, and that's all about it.
Okay. Thank you very much, Dr. Denny. So another participants would like to know how available it is to get ezetimibe and inclisiran in our own environment. Surprisingly, he just said about it only in this presentation. So I don't know, Dr. Denny, let me ask for Nigeria first.
Okay, fine. So inclisiran is not launched in Nigeria yet. And so, I will throw the question back to I'll throw the question back to the Novartis team on when it's going to be launched. Now, ezetimibe is available. Okay. Now, you may not find it in all pharmaceutical shops. You will probably find it in the big ones, because those who can stock it are the ones that have the wherewithal, so that you don't put such medication on your shelf and it expires. So you are going to find it in the bigger shop. So because I have patients who are on a combination of statin and ezetimibe, so it's available, but in the big outlets. That's why you find it. Inclisiran, we are waiting patiently for it to come.
Okay, no problem. Yeah, Dr. Steele, how was the situation like in Ghana?
Yeah, so for ezetimibe, it's quite similar to what Dr. Adeni said. It's available, but the use of it is very, very limited. Not many doctors are aware. Usually it's the physician specialists and cardiologists who recommend it, but it's very much available, just that the availability is very limited. Inclisiran, unfortunately, is available in Ghana. So I've not inquired about it recently, but it's been available in Ghana for quite some time.
Okay.
At least I know that it's been available since 2023. Yeah.
Okay. Thank you very much, Dr. Steele. Yeah, I think for me, I have a simple question. I don't know, is there a different treatment approach for patients with familial hypercholesterolemia, especially when they present at lower age group, at the younger age group? I'll start with Dr. Steele before I go to Dr. Denny.
Yeah, so as Prof said, these patients tend to have very high lipid levels, and they have very increased risk of cardiovascular diseases. So especially those with the homozygous tend to not to do too well. They may not respond too well to therapy. Some of them have very high lipid levels, which may require plasmapheresis, as Prof said. But you may be fortunate to have responses to the usual lipid-lowering therapy. Of course, the options we have are the same lipid-lowering therapies, apart from the plasmapheresis. Yeah.
Okay. Dr. Denny, I didn't even want to throw more light on that.
Well, Dr. Steele has said it all. It's a very rare disease condition. I do see them in my practice, because, but then there are not many. One, making the diagnosis is a challenge. It's a genetic problem, and you want to actually do the genetic profiling, which the patient may not be able to afford. That is one. But whichever way, we don't even wait for that. We want to start them on statin, and they are going to require a very high dose of statin. We're talking about pushing them to the maximum dose of statin, and we are not likely going to get them control. And so we need to add on to it and add on to it. So for the heterozygous one, yes, they tend to, they don't have symptoms, And we can, when we get them, we can manage them and prevent these cardiovascular sequelae. However, for those who have the homozygous, they die in childhood or adolescence because the LDL receptor is not there in the liver. So there is nothing to bring down the LDL cholesterol. And so in the very early stage, they have the coronary problem, carotid problem, and that is what kills them. But the treatment is the same. We use statin. If we are not getting to the target, we add a sentimine. If we are not getting to target, we continue to add as the patient can afford. And that is where the cost comes in. How many patients can afford those combinations? Now, the other thing that probably will come up is I've not seen that question, but I know somebody will want to ask. So, both of us have said the lower the better. The neurologists will be worried that, oh, in my stroke patient, if I lower it, they may bleed. But it's been shown that and their worry is that when you lower the lipid to a particular point, Dr. Steele did mention that the lipid also form the cell wall. And so if it's too low, when the cell becomes so fragile and a patient may bleed, but a lot of articles I've reviewed have not really pinpointed that some people bleed even when the lipid is brought that low. So I still stand by the fact that, and I agree with the Dr. Steele that the lower the better, and that is the way to go.
Thank you very much, Dr. Danny. Another participants would like to know if there are any foods or diets that we can advise patients to take to manage dyslipidemia. Dr. Steele, I'll start with you.
Yeah, certainly, and consistent with lifestyle modifications. The aim of dietary management in this condition should aim at minimizing the overall cardiovascular risk. And normally, diets which are high in saturated fats are known to contribute to lipid levels. So it's very important to avoid these diets, especially in patients who have dyslipidemias. And there's evidence to show that limiting the intake of saturated fats contributes to reducing LDL levels. And apart from that, it's also important to eat healthy diets, which will contribute to the person's overall health. So we all know about taking in fruits and vegetables, nuts, etc. As I presented, dietary risk factors was reported in one of the articles by the Global Burden of Disease. It was actually an analysis of the data of global burden of disease, which shows that dietary risk factors are the second most important cause of cardiovascular diseases. So on one hand, there is food to avoid to lower our lipid levels, and also food to take in to not only reduce lipid levels, but also to improve our overall, with respect to lipids as individual nutrients. Saturated lipids are known to contribute, saturated and trans fats are known to contribute to dyslipidemias, but unsaturated lipids are known to rather be beneficial for the purpose of reducing lipid levels. So we should know what saturated fats are, what trans fats are, and then also we should know what polyunsaturated fats are, because those ones are quite beneficial.
Thank you very much, Dr. Steele. Dr. Denny, I don't know if you have any other things to add.
No, I don't have anything to add.
Yeah, thank you very much. So one question here, I think you probably have answered it in a way. Will a patient with familial hypercholesterolemia be on statins for life, Dr. Denny?
Yes, it has to be for life.
So thank you very much. Yes, if you have any other questions, you can still put them on the chat while we'll take them. So another person will really like to know if there are specific foods that we can advise our patients to get. So what foods are high in unsaturated fat? Dr. Steele, do you have any idea about that?
Yeah, so unsaturated fats are usually from animal sources. Somebody made an interesting statement which may be useful. It says among animals, the more the legs and the bigger the animal, the higher the content of saturated fats. So, of course, 4 legs are top of the list. So we have big 4-legged animals like cattle, pig. You can be sure that those guys have a lot of fats. And then in a lower order, the goats and sheep, the rabbits, so in that order. And then birds, they have fewer legs, only 2. So they will also have less fat. But interestingly, fish lipids, they tend to be polyunsaturated, and they are rather beneficial. In some cases, they may even contribute to lowering lipid levels. So fish oils are quite safe. Animal oils, not so safe. Plant oils, they vary. You can have some plant oil sources that are saturated fats, which may not be very beneficial. And some it takes up things like palm oil. Palm oil, the palmitic acid is a saturated fat. So it's not very good for somebody who has dyslipidemia. But oils from plants like sunflower or even corn flour are quite rich in unsaturated fats, and they may be rather beneficial.
Okay, thank you very much, Dr. Steele. Yes, so we've put up the link to the form, the Microsoft Teams form, like we said earlier. You can please click on the link or the QR code that we put also on the chat to put in your details, give your feedbacks, let us know what we did right, what we did wrong, where we can do better, and put up your details so that we can get your details and send the CME points to you. Okay. There's another question here. Is the lipid lowering for life? Is there a stratification if target lipid is reached or during management? Dr. Steele.
But can you repeat the last question?
So is the lipid lowering for life? Is there a stratification if target lipid is reached or during management?
Yeah, those are very excellent questions. So certainly lipid lowering, dyslipidemia is a chronic condition, and its treatment is lifelong. So we shouldn't take patients especially those who are at very high risk. And there is a place for re-stratifying patients' cardiovascular risk, including even those with established cardiovascular disease. So there's such a thing as residual cardiovascular risk, where for a patient who has established atherosclerotic cardiovascular disease, put a person on various therapies, including lipid-lowering therapies. And then you can come to a point where you say, the residual risk of patients no longer includes high lipid levels. It no longer includes high blood pressure. Not that it doesn't include dyslipidemia, because dyslipidemia, once a patient has it, he has it. But you can see the patient no longer has high lipid levels as a risk factor. He no longer has high blood pressure as a risk factor, but definitely the person has hypertension. When the hypertension is controlled, lipid level targets are achieved, they can be taken out of the risk factors. And the ones that persist are those that are stated as the residual risk factors. And let me say that as a matter of fact, one of the goals of
I think we lost Dr. Steele there again. Dr. Denny, I don't know if you can chip in for us.
Yeah, I think he was discussing about being on a lipid for life.
Yes,
I
please.
think that was the question. We don't, like I said earlier, the treatment is for life. We may de-escalate the dose if need be, especially if we do the liver function test and we are seeing the effect of the statin on it, we may reduce the dose a bit. But basically, that treatment for those who have dyslipidemia, like Dr. Steele said, it's there, it's there. It needs to be managed uh, for the rest of the individual's life. So we don't need to stop it unless there are serious indications that contradict why that treatment should be continued. That is the only time we need to review it. And becomes very challenging because there are fewer drugs you can replace with. All the other drugs, like we've discussed, are hard on to statin. And so when you lose statin, then yes, not that others cannot work as monotherapy, but we know that we may not get as much response as we would if we're combining these molecules.
Yeah, Dr. Steele, welcome back. I think we'll just allow you to complete your thoughts.
Yeah, very sorry that I dropped off again. So as I was saying, one of the goals of managing cardiovascular risk is to lower the risk level. Unfortunately, for some risk categories like the very high risk, those with established atherosclerotic cardiovascular disease, there's very little you can do to change their risk level. They will remain at very high risk. People with diabetes will remain at high risk, but you can reduce the risk of subsequent events by reducing the existing risk factors and minimizing them. But those at lower levels, those especially are those that, as I mentioned, are categorized as people in, apparently healthy groups. These are people who do not have established cardiovascular disease or those who do not have diabetes or things like that. Those ones, they may start at high risk levels, but you can manage their risk factors to reduce them to a lower risk category. So somebody has high lipids, he doesn't have any other disease, you reduce the risk level. The next time you use the AfroD CVD risk score, and based on the current parameters, the risk score will come lower. So it's very much possible to reduce CVD risk burden, and then that should actually be part of our targets in managing these patients.
Thank you very much, Dr. Steele. Another person is concerned about the side effect of statins. Dr. Denny, I don't know, in your patients who you've placed on statins, have you had the opportunity of managing those who came down with myopathies? And how did you manage them? Dr. Denny, you're muted, please.
Yeah, okay. I've seen
Yes.
quite a lot of people who have myalgia. Myalgia is what we probably see more than the myopathy is the extreme of it. Now, the myalgia is a class thing. So long as it's statin, the patient may have, myalgia. And the way to handle it is sometimes when we reduce the dose, the myalgia disappear, then we can now escalate. In some people, it's self-limiting. After some days, the myalgia disappear, but in some, it can be worse. And in such individual, it's advisable to reduce the dose, then escalate it so that we can get to target. In some individuals, they won't be able to tolerate it at all, and that's where the challenge is. For the myopathy, the same thing. We'll reduce the dose or remove it if the myopathy is quite severe. We take the patient off the drug and let that event clear. Then we may now reintroduce the drug at a very low dose and build up.
Thank you very much, Dr. Denny. Dr. Steele, I don't know if you have any other thing to say.
No, that is very much well explained. I don't have anything to add.
Yeah, thank you very much. So I think we would stop the questions and answers here. So once again, please, we have put up the link to the forms. You can please click on the link, fill the form, give us your feedback, and give us your details also so that we can send you your CME points. You can also scan the QR codes, and it will also take you to the form where you can give us your details. So I'll be handing over to my colleague Evelyn to give us our closing remark.
All right. Thank you very much, Sajid. And I've seen some people ask for the slides in the chat box. So we will communicate that to you later. And it's very important you fill the feedback form and you give us your email address so that when we've gotten our right approvals to share the slides, we can use that email address to forward the slides to you. Thank you. So we would, first of all, would like to thank our esteemed speakers for their outstanding delivery and contribution to the knowledge of our participants today. So Dr. Denier, Dr. Stildazi, thank you so much for this excellent delivery and education. Secondly, we would like to thank our participants for today for taking time off your busy schedules to be here with us. And we hope that the learnings for today will be put into practice in the management of patients living with dyslipidemia. First of all, to improve patient outcome and also to prevent avoidable or avoid preventable deaths for patients living with this condition. We would like to thank the Novartis team that made this program possible. So thank you all very much for participating in today's webinar, and have a very good evening. Thank you.
Thank you very much for having me.
Thank you very much.
And let me thank Dr. Steele. I've learned one or two
Thank
things.
you very
also.
much, Professor. I've learned a lot also. Bye.
Right. Thank you.
Thanks a lot,
Okay, bye-bye.
Evelyn.
Thank you
and
to
your
Dr.
colleagues.
Stildazi.
Right.
Thank you.
Okay, bye-bye.
Bye. Please don't forget to fill the feedback form. Those on CES platform, you can also scan the QR code, give us your feedbacks, and then please make sure you go on the CES platform, especially for those participating from Ghana, and take the post test to be able to get your CPD points after. Thank you very much and good evening.